uh, in the next few minutes, but we've started the recording, if that's okay with everybody. So welcome to the AFNet webinar. My name is Professor Anne Whitaker from the University of Stirling in Scotland, and I'm one of the AFNet trustees. So AFNet exists to bring together practitioners and researchers and policymakers, experts by experience, who are all interested or involved in the effects of somebody's alcohol, drug, or gambling has on other members of the family. We have more than about 850 members from 58 countries across the world. And you can learn more about AFNet from our website. And if you're not already a member, you can join for free by completing the application form that's on the website, and that will also give you access to member-only resources. So among the many things that AFNet does, we do our conferences and this webinar series. In alternate years, we hold either a face-to-face conference or an online conference. And the next face-to-face will be this year in May in the lovely city of Quebec in Canada. So hopefully many of you will plan to attend the conference and have also submitted abstracts too. The programs and the recordings of all previous conference presentations are also on the website. So the webinar that we're going to hear today is part of the webinar series. The webinars are free, but as a small charity with no funding sources, donations from those who attend the webinars are always welcome. Again, details of how to donate are on the website. And from the technical side of things, running the websites, the video conferencing, etc., are undertaken by two colleagues in Finland who work for the A Clinic Foundation, Sarah June Van Su and Janie Takala. So a huge thank you to them. There might be somebody here that can probably pronounce their names better than me. But anyway, the webinar series has been running since October 2020. And the presentations are all online on our website as well, if people want to catch up on a wide range of excellent presentations that we've had so far from all over the world, including Australia and New Zealand, Indonesia, Malaysia, many of the European countries, and also Canada, USA, and Brazil. So, no further ado, today's webinar comes from Sweden. I'm just clearing so I can see everybody. It comes from Sweden, and it's my great pleasure to introduce you to Dr. Tobias Elgán, who will give a talk titled The Effectiveness of a Web-Based Individual Coping and Alcohol Intervention Program for Children of Parents with Alcohol Use Problems and RCT. So Tobias is an associate professor at the Karolinska Institute in Stockholm. His research focuses on prevention science with an emphasis on developing, implementing and evaluating interventions to prevent substance use and related problems. Many of these are multi-component, community-based alcohol and drug prevention programs, primarily implemented in nightlife and entertainment settings. For over 15 years, Tobias has also conducted research on young people growing up in families affected by substance use, with a focus on reaching this vulnerable group with easily accessible support using digital interventions. So Tobias will talk for about 45 minutes, and then we'll have time for questions and answers. I think you'll all be on mute for the presentation, so please, if you've got any questions or comments, add them to the chat function, and we'll answer them and look at them at the end. Or at the end, you can simply just use your raise hand function, or else just wave, and I will try and see you. Okay. So now over to you, Tobias.
Thank you for the nice presentation. So I will share my screen here. Can you see the presentation? Yes. So first, I would like to thank the organizers for inviting me to present at this webinar. And the outline is as follows. I will first briefly present our unit, STAD, and then I will go into the problem overview and problem context related to children who have parents with alcohol problems. I'll then present the background to alcohol and coping, which is a digital intervention, and I will share some content from the program. And then I will go into the evaluation and results, and I will briefly mention yet another digital intervention that we have evaluated called Grubbel, and also a forthcoming new project on a digital intervention. And I will end the presentation with conclusions. So STAD stands for Stockholm Prevents Alcohol and Drug Problems, and we were founded in 1995. We are a research and development unit at the Center for Psychiatry Research at the Karolinska Institutet and Region Stockholm, which provides healthcare. And the aim of our unit is to develop, implement, and evaluate prevention methods. And we are both researchers and practitioners that work in close collaboration in our projects. And one goal for us is to bridge the gap between science and practice. And we conduct work on a regional, national, and also international level. And during the years, we have developed several alcohol and substance use prevention methods. For instance, student and football not binging, which are two alcohol prevention programs targeting student parties and drinking at large football events. Another method is Clubs Against Drugs, which targets substance use and related problems in the nightlife setting, and 100% Pure Hard Training, which targets doping use at gyms. And currently, we have a national mandate from the government to coordinate both Clubs Against Drugs and 100% Pure Hard Training on a nationwide scale in Sweden. And all these programs are adapted from our program, our original program in Responsible Beverage Service. So this was our first program developed in 1995. And all these programs have in common that they share the same basic program components, being community mobilization and collaboration with stakeholders, training of stakeholders and staff, for instance, at licensed premises, and improved enforcement by, for instance, the police authority. So I will just very briefly present some of the results that we have seen from our evaluation of responsible beverage service in the nightlife in Stockholm. So for instance, we have looked at the refusal rates of alcohol service to obviously intoxicated. And here we have done so-called actor studies, where we have trained professional actors to enact a standardized scene of obvious alcohol intoxication at the same time as the attempt to purchase a beer at licensed premises. And at the baseline in 1996, they were refused service in only 5% of the attempts. And as you can see, this figure has increased over time quite markedly. We have looked at alcohol-related violence and seen a 29% reduction in alcohol-related violence in Stockholm during the years we have worked with the program. And based on this reduction in violence, we have had health economists look at cost savings ratio, and they concluded that for every euro that we spend on the work with responsible beverage service, the society saves 39 euros due to lost costs for healthcare and police work, etc. And these results have also led to a international dissemination of the program to 6 other European countries in a EU-funded project called Start in Europe. So that was a brief introduction to our unit, STAD, but now let's go from the nightlife to children of parents who have alcohol use problems. And in Sweden, a number of studies have been done to estimate the prevalence of the problem, and these numbers are quite similar to what have been observed in other countries. So, for instance, between 13 and 20% of all children in Sweden have a parent with problematic drinking, and 4 to 5% have a parent with alcohol use disorder. Regardless of the exact figures, there are many children who are affected by parental substance use problems. So 4 to 5% corresponds to 90,000 Swedish children. 20% corresponds to more than 400,000 children in Sweden. And of course, this may have negative consequences on the children. So, for instance, there are risks for earlier alcohol initiation and problematic substance use. There are a risk of depressive symptoms and anxiety symptoms, higher levels of stress, etc. But it can also be about children having feelings of guilt, shame, and betrayal, and avoiding bringing friends home. Many are also young carers, and they take too large responsibility at home. That can, for instance, be caring for younger siblings or making sure that there are food at home, etc. And obviously, this may also have a negative impact on school performance. And research also shows that when they are adults, they have an increased mortality risk. And these are quotes from 2 girls that have participated in our studies. So one girl, 17 years old, says that we were supposed to have dinner in the living room. Dad ruined the whole evening because he had been drinking and turned into someone else entirely. My brother went to the kitchen, Mom went to watch TV, and I went up to my room. And another girl, when I feel bad, I often cry. I go away, lock myself in the bathroom and cry. Then when I come out, no one notices anything. It hurts. So these 2 quotes illustrates that they are often alone in coping with their situation and don't have anyone to talk to. I mentioned that this may have consequences in adult age, and I was one of the researchers in a Norwegian study among 28,000 individuals in Norway, where we asked about parental alcohol problems during childhood. And we could see that the proportion that have parents with alcohol problems were higher in more vulnerable subgroups. Like, for instance, it's higher among those who have primary school as their highest educational level, as opposed to secondary school or higher education. It's higher among those who are unemployed, as opposed to being employed. It's higher among those with low economic ability to manage daily expenses. And it's also higher among those with financial assistance. So these results further illustrates that having parents with alcohol problems may have large negative consequences in adult age. And there are support available in Sweden. So there are surveys yearly that is conducted, and those surveys show that almost all municipalities in Sweden offer some kind of support, most commonly individual counseling or support groups. There are also support available via non-profit organizations. But at the same time, figures also show that there is a very small proportion that are reached by available support, so only 1 to 2% of those who may be in need of support. So there is a huge gap between those who may be in need of support and those who are actually receiving it. And this gap may be due to challenges in identifying and not least recruiting children into this support. So where can these children then be reached? Well, obviously, the school can play an important role in identifying these children, and they can work with competence development of staff. They can work with policies and action plans. One hindering factor may be that people don't or staff don't know where to refer children if they ask about their home situation. So rather, they don't ask about their home situation. And a few years ago, I did a national survey among schools asking about their policy work related to children who have, or students who have parents with alcohol problems. And results show that 20% of schools had not identified a student having parents with alcohol problems, which is kind of remarkable since it is so prevalent. 1/3 of all schools had a policy and action plan. And we also saw that if a school had a policy, it was more likely that their staff had some competence development. And this in turn increased the likelihood that schools were better in identifying children. And student healthcare can, of course, play an important role and be better equipped in this issue, since they are supposed to meet all children at least 3 times during primary school years. Yet another arena where children can be reached are through healthcare clinics and social services. And for instance, staff at healthcare clinics and social services can ask their clients that are enrolled in addiction treatment if they have children at home, and also inform that their children may be in need of support and see to it that they actually enter support. They can also work with policies and action plans, and one way to make this work more structured is to work with a so-called collaborative individual plan. So according to Swedish law, clinics and social services should use this plan if they have clients in need of care from more than one branch of the care network. And a few years ago, we did another survey among psychiatry staff and staff at addiction clinics and social services, asking about their collaborative individual plan, and if the plan included a question whether the client had children at home. And results show that 30% reported that their plan included a question if the client had children. And among those who reported that their plan had a question about children, 83% made sure that children received support, and 63% followed up that the children received the support. And yet another arena where we can reach children are through digital media. It's an integrated part of daily life, and it's connected to less stigma and promotes an anonymity. And it also, of course, increases accessibility of support. Yes, and these are 2 quotes from 2 other participants from our studies. So one girl says that I never talked to anyone about the addiction in my family, but now that it is an online course, it feels like it's worth a try. And both my parents are alcoholics, and I never wanted or been able to talk to anyone about it. I think it was the anonymity that made me want to participate. And both these quotes highlights that anonymity is a facilitating factor, and other factors to why individuals want to participate in digital support may be that it increases availability, it's easier to talk to someone via digital media. I mentioned anonymity, but it also reduces stigma as opposed to looking for or going to the social services for support. So for this webinar, I was asked to present results from one of our digital intervention, which is called Alcohol and Coping, which is a digital therapist-assisted self-help intervention. And a brief background to this intervention. It's based on a manual-based face-to-face program called ECIPE, or Individual Coping and Alcohol Intervention Program, which was developed by Helena Hansson and Ulla Zetterlind at the Lund University. And it's targeting university students with parents who have alcohol problems. And it's two-hour sessions, face-to-face. And the ECI program was evaluated in an RCT with a 12 and 24 months follow-up. And results show that the program had positive effects on the participants' own alcohol consumption. So participants in the intervention group reduced their consumption, while participants in the control group did not reduce their consumption. Experiences from the ECIPE and results have been included in Helena Hansson's dissertation. And the program builds on educational strategies to inform and empower participants. It's based on risk and protective factors with a focus on strengthening coping abilities. And what we did was that we digitalized the program and adapted it for a younger age group, 15 to 19-year-olds. And it consists of film-based lectures, questions on alcohol and coping with automatic feedback. And there are exercises and then also therapist-based feedback. And this is what the program looks like when you log in. And it looks like a board game, and you need to go from start to finish. And to do so, you need to go through all these film-based lectures, the questions and exercises, and so on. And I'll show you the introduction that the participants receive when they start the program. And it's in Swedish, but I found an AI-based voiceover tool, so you will hear the translated version.
Hi, my name is Per and I would like to welcome you to Alcohol and Coping, a program for those who live in a family with substance abuse problems. Do you know what coping is? Coping is a bit difficult to explain in a single word, but you can say that coping is how you relate to a difficult situation. As a child in a family with substance abuse problems, it is easy to feel fear, disappointment, shame, and even blame yourself for things that are actually not your own responsibility. It is not always you who can change the situation, but you can influence how you relate to it, how you think, feel and act or do not act. When faced with the problems an addiction can cause, different patterns of attitudes sometimes arise. Patterns that you can feel more or less good about. Often you can get a little better if you take your time and think through how you usually relate to the problem. Was it possible to influence the situation? Did what you did have any effect? Did it get better? And how did you feel? Or could you have behaved in a different way and then perhaps you would have felt better? Otherwise, it is easy to adopt and repeat a behavior that makes you feel bad in the long run. And that's really what this program is about. To become aware of problems and how to react to them. To find ways to handle everyday life so that you can feel a little better. And actually get a better life. Because you have the right to a good life regardless of whether your parent or relative stops or continues to abuse. We will talk about how alcohol works and how a mother's, father's or another relative's addiction can affect family life. We will talk about coping, about how to deal with difficult situations that an addiction can create. We will talk about how others are doing and how you yourself think and feel and act. You will then receive a personal letter from our therapist, and by then you have told us a little about yourself. It can be nice to get some advice and views from someone outside the family. The program ends with us trying to look a little into the future at what goals you can set for yourself and how you can do to achieve your goals. Start by watching the movies about alcohol in the family.
Yes. And as Per mentioned, there are 3 film-based lectures about alcohol. So the first one deals with dependency in general, and it talks about risk and protective factors, genetic and environmental risk, tolerance, social networks, etc. The second film is about patterns within the family and how the family adapts to the one with alcohol problems. And the third lecture is about attitudes toward alcohol and how it influences drinking, talk about intoxication and risk consumption. And this is an example from the first film-based lecture about addiction in the family.
A lot of research has shown that if you have a mother or father who is addicted to alcohol, you can also have an increased risk of developing an addiction to alcohol at some point in your life. But it's not like you automatically become an addict because you, for example, have a father with an alcohol problem. The increased risk could be compared to the risk of developing diabetes if you have a parent with that disease. Then you might try to think about how important it is to move, exercise, and try not to get overweight. It is just as important, if you have a parent who has problems with alcohol, that you think about how often, how much, and in what context you drink. In both of these cases, it is good that you are aware of the risk and try to protect yourself. All children and adolescents, regardless of whether they have a mother or father with an alcohol problem, should abstain from alcohol until they are 18 years of age, that is, until they are adults and their body is fully developed. The fact that there is an increased risk of alcohol addiction does not mean that later in life you have to abstain completely from alcohol. There are a number of factors that protect against alcohol addiction, and there are factors that increase the risk of misuse or addiction. Research has not yet found a specific gene, but various studies conducted over the years when it comes to children and alcohol-addicted people have shown that there is a considerable risk. One sign of risk is that you can feel a greater kick when you start drinking alcohol compared to friends who do not have the same background. It can also be that you can drink much more alcohol than your friends without becoming more drunk. Another risk factor that is often raised is the risk that can arise due to the environment you live in. This means that, as a child, you can take after your family members' way of dealing with and solving problems, just like the family's way of dealing with alcohol. Families where a member has an alcohol problem can function well despite the abuse, but it often happens that the abuse of the relative leads to various problems arising in the family, with, for example, a lot of fight and worry. This affects how everyone in the family feels and can give anxiety and depression and an increased risk of abuse. How big the risk of abuse is, in other words, an interplay between inheritance and environment. A lot of research has shown.
And there were some coping-related exercises, like for instance 4 vignette-like stories from 4 fictional persons describing everyday life related to coping. So to the left you see a letter from one of these fictional persons called Philip. So he describes his everyday life, and and before this exercise starts, there is a short introduction by Per.
Children who have grown up in a family with substance abuse problems can often feel let down by parents and others. This sometimes leads to you also having difficulty trusting what others around you say and promise. If you don't dare to trust others, it can mean that it becomes difficult to develop close and firm relationships. To protect yourself from disappointment, It can sometimes feel easier to try to shut down your emotions. It's something that adults also do sometimes to be able to cope. In difficult situations, it may feel necessary to switch off. But if you live with the problem for a long time, then there is a risk that the suspension will be permanent.
So then you're supposed to read this letter from Philip, and then you're supposed to write some tips to Philip on how he can cope with this home situation. And then there are also 2 exercises related to the participant's own situation at home and coping. And then the intervention concludes with the feedback from a therapist based on the exercises that the participants have done, and also on their answers to questions on their own alcohol consumption and their coping behavior. So that was some information about the program. So let's go over to the evaluation. So we evaluated the program in an RCT with 2 and 6 months follow-up. We recruited participants on social media. And so we had ads on social media, and more than 2,700 clicked on the ad and completed a screening. And here we used the Children of Alcoholics screening test, which is a screening instrument developed in the 1990s. And it consists of 6 questions. For instance, have you ever thought that one of your parents had a drinking problem? Did you ever encourage one of your parents to quit drinking? Or did you ever argue or fight with a parent when he or she was drinking? And the cutoff that we used was 3 or more yes to these questions. And we have also done a psychometric analysis of this CAST-6 instrument, which showed that among Swedish adolescents, and found good to excellent psychometric properties of this screening instrument. So more than 2,700 clicked on the ad and did a screening, and almost 1,300 had 3 or more yes on the screening instrument and were offered to participate. But not too surprisingly, many did not want to participate in the study, and we ended up with 204 who consented and were allocated to the intervention group or control group. And we measured coping using the Coping with Parents Abuse questionnaire. We measured depression using the Center for Epidemiological Studies depression scale. Alcohol use was assessed by Alcohol Use Disorders Identification Test, the short version consisting of 3 questions. Overall life satisfaction measured by ladder of life, and we analyzed the data descriptively and with the linear and generalized linear mixed models. And if we start by looking at the baseline data, we get a feeling for who we reached through our ads on social media. And the mean age was 17 years, 88% were girls, and 78% had depressive symptoms, of whom 55% had severe depression. 43% had dysfunctional coping behavior, and 40% had own risky alcohol consumption. And remember now that the mean age was 17 years. 80% had not been in contact with other support, and a majority had never spoken about their situation with an adult. And before we go into the results of the effects of the program, I'd like to say a few words on program adherence. So we had 101 participants in the intervention group, 64 logged in and registered to the program, which means that 37 or 37% did not. So here we lost 37%. 35 persons or 35% completed the alcohol intervention only, and 24% completed the alcohol and coping intervention. So they completed the whole intervention. So we can see here that we had quite a big loss or low program adherence. And this can, for instance, be explained by a high proportion having symptoms of severe depression, that they may not be have the motivation or ability to go through the program. Maybe the film-based lectures were too long, so they were between 7 and 15 minutes long, which is quite a lot. We also had a break built into the intervention. So after the alcohol part, they were supposed to take a break and then continue with the coping part. So we discussed that the alcohol intervention part was quite extensive and they needed a break. But then we also saw that people did not log into the program again. So what about the effects? We saw a tendency toward reduced depressive symptoms. So for instance, at the 6-month follow-up, we saw a small effect size, but this result was not statistically significant. However, we did see an effect on the user's own alcohol consumption. So at the 2-month follow-up, the intervention group had 38% lower scores than the control group. And at the 6-month follow-up, the intervention group had 46% lower scores compared to the control group. So we could then conclude that the program had effects on participants' own alcohol consumption, and this was also in line with the results seen in the original face-to-face ECAPE program, where the participants also reduced their alcohol consumption. So what did we then learn from this study? Well, we found that the digital therapist-assisted self-help intervention can reduce the adolescent's own alcohol consumption. We had inconclusive results on all other outcomes, which may be due to the low adherence. It also highlights the potential for digital interventions to reach a large, vulnerable, hard-to-reach group of adolescents with support. And the alcohol and coping intervention is quite brief. It takes like 1 hour to go through, but this may not be enough for the vulnerable sample that we reached on social media. I will just quickly mention another study that we have done on a more extensive program called Grubbel. So this is a therapist-guided digital group chat intervention. We found this program in the Netherlands. It's called Koopstoring. And this is much more extensive than the alcohol and coping program. So the Koopstoring or Grubbel intervention consists of 8 group sessions. Each session is about 60 minutes where they chat with each other, and each session is moderated by a trained therapist. And we evaluated the program in an RCT with a 6, 12, and 24 months follow-up. And the target group was 15 to 25-year-olds having parents with substance use problems and or mental illness. Again, we recruited via social media, and 156 participants were included in the study, 98 participants in the intervention group and 58 in the control group. The mean age was 19 years, and again, we see that it was a majority of girls, 82%. And again, we saw that we had reached a vulnerable group. So 60% had depressive symptoms, 44% had their own risky alcohol use. We also saw a low adherence. So only 19% of the participants completed more than 50% of the program. So more than 5 or more sessions out of the 8 sessions. And preliminary results show no between group differences. So what have we then learned from these two studies? Well, we have reached a vulnerable group of young people on social media. We see a low program adherence, calling for more engaging programs. And here we can use strategies of co-production with the end users, with the adolescents or young adults themselves to create better suited interventions. So what's next? Well, we last fall, we were happy to get information that we received funding for a new project where we will develop and evaluate a new digital intervention. And this is a collaborative project with researchers from Uppsala University and Lund University. And Ola Siljeholm, who is with us today, he will lead this project. And the aim of the project is to co-produce and evaluate digital preventive interventions for 15 to 25-year-olds with parents who have alcohol problems. And we will explore how the intervention is received, whether it is effective, and also if it is cost-effective. The project is divided in 4 work packages. So the first work package deals with developing the intervention. And as I mentioned, we will co-produce the intervention with the target group and also with relevant stakeholders such as student healthcare clinics, social services, healthcare providers, and also non-profit organizations. The second work package is a pilot study where we'll test the feasibility of conducting this an RCT and also test the program. We will recruit 30 participants. We will do semi-structured interviews and a baseline assessment and a 1-month follow-up assessment. And if needed, then we will do some modifications to the intervention. This is then followed by work package 3, where we will do the full-scale RCT with 400 participants. And as you can see, we will do follow-ups at 1, 3, and 12 months. And the final work package is cost effectiveness, and this will be done by colleagues at Uppsala University. So to conclude, there is a need for more accessible support, and digital solutions can serve as an important complement. Vulnerable, hard to reach group of young people can be reached via social media, and digital interventions can potentially play an important role, but we have seen problems with low adherence. And this then calls for more tailored interventions. Thank you.
Thank you very much, Tobias. Really interesting and presentation. And nobody's added any questions to the chat, but I'm sure you've stimulated a lot of thinking around interventions for young people. Now, I'm looking around to see if there's any hands up. I have a few questions, but Gauss, come on in.
Yeah, thank you very much for this very interesting study. I just in order to better understand it, did I get it correct that you presented the intention to treat analysis results? And so I just wonder whether you considered to also do a kind of completers only analysis.
We did that. So the results I presented was intention to treat analysis, but we also did completers only analysis, and we saw no difference.
And Tobias, just to help me understand the intervention a little bit more, what was the kind of main aim and primary outcome measure for
so
your
the primary
RCT?
outcome, yes, thank you. So the primary outcome was coping. And we didn't see any differences there at all, unfortunately. Yeah. So the alcohol part that we saw effects on was secondary outcome.
Right, right. That's really, really interesting. Richard, come on in.
Thank you, Anne. Thank you, Tobias. What a both excellent presentation and also excellent study and excellent range of work that you've done in your unit. I mean, I don't think we have anything comparable to that, unfortunately, in the UK, where I could say we've done all these marvelous things you did about changing refusal rates and server stuff, and reductions in alcohol-related violence, the things you've done in communities and community centres are absolutely marvellous, leaving aside all the work you're doing on families and children, although obviously they're linked. I thought lots and lots of what you presented was absolutely excellent. I thought the program looked really excellent. By the way, I really like the AI translation, although I'm not 100% certain of why there was an Australian voice. But
I choose so.
Perhaps
I could choose
to make
British
Anne,
English.
make Anne feel happy. So I think that I think what you're touching on what I consider to be one of the real problems, but potential good things about digital interventions, which is that they are extremely good as public health interventions. They have very wide reach and they can get an awful lot of people, but they have the major drawback, which is that they're not personal. And you can use AI bots and lots of ways to try and increase that potential to make people feel that they're dealing with a person, but fundamentally they're not. And what I think we know about an awful lot of therapeutic interventions is that engagement, human engagement, is one of the absolutely central things in the therapeutic link that happens. What you get with digital interventions is obviously you don't get that, but you have the potential to reach very large numbers of people. And the whole thing about the public health model is that if you only reach 10% of the people and make a change in 10% of the people, then you are making a massive population-based change, even if 90% of people don't engage. If you try and develop a human-based intervention and you only reach 10% of the people that want help, then that's not a very good result. But it's a very good result on a public health basis. So I'm just concerned that you're going down, or not concerned, but wondering if you're going down a route of trying to integrate what you would expect of a human-based intervention into a digital one, instead of saying, look, we've done very well to get 10%, but 10% of 120 people is very, very little. What we need to get is 1,000 people or 10,000 people, and then we're going to see some major results. Because I think all your results are going in the right direction. It's just that this is, for the numbers you've got, it's massively underpowered. So my question is, do you think you should be going more for a major public health approach, trying to get large numbers in and trying to make a difference to only a small percentage of them, as opposed to trying to do the human-based approach, where I think you're having a big problem with engagement? And even if you co-produce it, as I don't think the problem is the intervention. So co-producing another one doesn't necessarily mean that young people will engage with an online digital intervention, which is not human-based.
Well, hopefully it will do something to the program adherence if we co-produce it with the target group. But you make a really relevant point here, that maybe one should consider like balancing or agreeing that the program adherence, a low program adherence is okay, based on your public health arguments. So I completely agree. But the problem I see is that I mean, we need to show effects also on the programs, and I mean, recruiting 1,000 or 1,500 persons to a program or a study like this, it's going to take a huge amount of time. We don't have that time when we are on tight budgets. But yeah, I understand.
Very good. I'm going to come in and disagree with Richard. I think my experience of working with young people affected by parental drug use is that any intervention, unless it is co-produced, is almost doomed to failure. I think it's definitely worth, in the development of complex interventions, it's definitely worth the kind of effort and time and challenge, if you like, of co-producing something that's going to be much more suitable for the target population. And I think I also disagree with Richard in terms of the potential usefulness of a digital intervention, particularly for young people. Actually, young people more and more don't want human interaction. They are interacting via a different kind of medium these days, and the kind of anonymity and the expressiveness that they can achieve through digital communications is quite astounding. And I think the opportunity now with digital interventions is they can be designed to offer personalised care. So there's been huge leaps forward in digital interventions. So I think that opportunity, particularly to personalise interventions for young people that have been co-produced by young people for young people, there's a big opportunity there, I think, to develop and bridge that kind of sense of isolation that a lot of young people will describe and talk about. So I think there's a lot of opportunity there. So it sounds like the next steps of co-production, I think, are going to be extremely worthwhile. And it might be that work gives you some very good ideas about how to personalise the intervention in a way that's going to be more engaging and, affect your dropout rate, hopefully reduce your dropout rate. One thing that I thought was interesting was the gender difference in all the studies that you presented. You're talking 80, almost 90% women. So what's your thoughts about that? How would you explain that?
I think that's what many others have seen too in their studies, that they recruit much more females into the studies. And why that is so, I'm not sure, but one could speculate that maybe females are more prone to seeking support in general. I mean, I've also been involved in other programs, the digital programs, trying to reduce alcohol and drug consumptions among risk users. And there we had a much more equal distribution between genders. That's quite interesting, and I don't know why that is.
Interesting.
So maybe
but
someone else has a good thought on this.
And it does pose a challenge in terms of how then do you reach the male population, young men. But through the co-production, it might be that young men involved in that co-production may provide some guidance as to how to present it potentially in a gendered way that's going to attract different genders. Very good. Any other questions? I can't see any hands up. Oh, there's a hand waving. Steph, come in.
Yeah, I don't know why I've lost my hand. Tobias, that was fascinating. Thank you so much. It was just a couple of things with me. I think one is when you're actually doing the research. Sorry, Richard, if I misinterpreted what you said, but I think if you're looking at research going out on a public health level, in the UK, Tobias, my background is in gambling harm, and in the UK, I noticed a lot of universities tend to use, for affected others, groups that are already set up. And I think there's influence within group, which could be factoring into your gender as well. I think we get too focused in going to do group work to obtain the data that we need, and that can be quite influential, which might be why you've got more girls, because it's like the leader of the pack says, right, yeah, I'll do that, I'm going to sit in, and my mates would all do the same. For instance, if I said I was going to have a bottle of Prosecco, I know they'd all be jumping in, and that's a really bad thing for me to say at this webinar. So I think there is that in mind as well, and I think having varied types of sessions and one-to-ones maybe, you might have better interaction for males, as opposed to maybe in a bit, but like a school forum, you're going from the same environment thinking about maybe different environments. And I think in the UK, that's where we go wrong. We tend to go to lived experience that are already established, and they will all be singing off the same page. They're all going to say the same thing. They're all going to follow in line, because we do, don't we? It's more looking maybe at that individual, even mixing the sexes, separating the sexes, that could help.
Good suggestions, yeah. Because you do get the group norm effect, don't you, for these type of co-production type things. Very good. Okay, the other more from a more critical perspective, Tobias, the intervention to me appeared to be kind of pretty deficit focused. So it talked a lot about problems and a lot about risk. And I'm just wondering if you've had any feedback from the young people who engaged in the program around the kind of whole orientation of the intervention and how it was perhaps, although the main aim is around a kind of strengths-based outcome, i.e. improved coping, the orientation of it, as and we only saw a little bit of it, that might not be how it the totality of it, but it did come across as what I would call your fairly kind of classic deficit-based model approach, talking about risk and disease and problems that you're encountering. What's your thoughts on that?
I mean, as you said, I only showed a small part of the program. It also mentions it is more positive in some ways also, but I think you're right in it that it kind of focuses on risks and so on. We unfortunately did not do. I mean, we could have done a qualitative study to follow up what they thought about the program. We did not do that. The program is based, as I mentioned, the program is based on this manual-based face-to-face program. And that one is actually still ongoing in Sweden. So there are student healthcare clinics at several universities that are still using the program, which is quite remarkable because it was developed in like 2005. And I'm not sure if Helena and Ulla did studies on how the end users experience that program, but we have talked to to staff at the student health clinics that are still using the program, and they are so engaged and motivated to use the program and have so much good experiences from the program. So yeah, it's not quite an answer to your question, but
Good feedback, yes. So, and in your future study, you're thinking of integrating some kind of qualitative aspect to the follow-up,
yes.
1,
Yes.
3, and 12 months. Great.
Yeah.
Gallus, come in.
Yeah, just another question. You mentioned, as far as I understood it, that you have services for these children affected by parental substance use problems all over Sweden. So I just wonder, has there ever been a study or an approach more into a kind of referral to these services? I think the big issue about your intervention is that people contact you who otherwise have 80% had no prior treatment experience, as far as I get it. And I just wonder whether there might be other strategies to get them into the existing services. And so I just wonder, have you ever considered this, or has this been done? Because I also felt the intervention was quite strongly focused on cognitions, while I feel that especially validation is really important in family members. And I'm not so sure whether this can be adequately done with digital interventions. So I'm a bit more Team Richard on this issue. And just another question I had, did you also checked out how many of your participants had both parents affected or only one, and whether mother or father, and whether this had an impact?
We asked about whether it was mother or father. We did not. Maybe I'm saying too much now, but I don't think we looked at included that in the models, that information. Otherwise, I mean, other studies have seen that if you have a father, right, then it's more negatively influenced on the children, I think.
Well, I think it's always a bit tricky, because mostly it's the fathers who are affected, but quite often the level of attachment is bigger to the mother. So
Yes.
I think on an individual basis, it might be a bit more complicated.
Yeah, but then you asked about approaches to get the children into existing support, and I'm not aware of any studies that have looked at that specifically, but I mean, I presented some studies that we have done where we asked about if schools talk about this and if they use policies and so on. I mean, that would be something. And also, I mean, if you have clients in addiction clinics or treatment, then it feels natural that you should ask them if they have children at home. And that's not always the case.
But Tobias, I don't think that's quite what Gallus was meaning. I think it was more you potentially recruited, you found 1,200 young people, and you made them the offer of coming into a digital program, of which 200 and something said yes.
Yeah.
And I suppose the question is, what would have happened if you had, to that 1,200 people who scored positive, if you had said, would you like us to put you in touch with your nearest service?
Okay.
I wonder how many of them might have, and for that matter, was that something that you thought you could offer to the people who didn't
We did
screened
actually
positive
offer
but
that to
declined.
all people. So we had.
Do you have any data on what happened?
No, but we don't have any data on that. But we did offer or referred to web pages that in turn referred to support in Sweden.
Right.
But no data.
I mean, you can't ask questions about everything, but I think it's a very interesting thought about because what we know is that there, and what you've discovered and got good evidence for now, is that there are a huge number of people who are out there who are not accessing services, and what we don't know why they're not accessing services. And of course, that's a very important question, which it would be very nice to get an answer to.
Yeah.
Why are all these young people, they see something on Facebook or some internet thing, and they click onto it, and they're motivated enough to go through the screening process. And you discover that lots of them have the experiences that we're interested in. What we don't know is why they haven't accessed services. And then you offer them a digital service, and 10% of them, 20% of them agree that they're to take part. We don't know about the 80% who didn't agree to take part. And that's a very interesting group, really. You've accessed them, and they've told you they've not accessed services before, and then you make them an offer of a digital service, and most of them don't take it up. You tell them about other services that exist, but you don't know whether they're able. They've done that, nor why they haven't accessed those services before. So there's a whole. You've got access in a sense. If you were to replicate this study in some other way in your next phase, you've got access to a group of young people who would be really interesting to find much more about, and maybe a qualitative study at that point to find out about why people haven't gone to treatment before, or got any help before, got any support before, and even why they're saying they don't want to take part in this digital support, which is more anonymous, all the things that you said about it, which are very positive.
Yes, thank you.
Maybe just to add what Richard just said, if I understood it correctly, you had this screener, and it was an exclusion criteria if people didn't have, I think, 3 points or something.
Yes.
And I just wondered while having a look at the questions whether this screening tool is sensitive enough, because I would wonder, why would anyone contact you who, well, does not count in as being affected by parental substance use problems? So probably if I think 2 questions were about, have you asked them to cut down or whatever? So for example, if someone is really shy and the parents are not violent and so on, then it's quite likely that the person wouldn't score on this screening, but still might be severely affected. So probably just as a suggestion for the next study, if you decide to use the screening tool again, then I think it would be interesting to have a closer look at the ones who otherwise would be screened out.
I mentioned that we did a psychometric study of this screener, and we actually concluded that the optimum cutoff was 2 points, not 3 points, in this sample. Good point.
Right. Yes, presumably you are wanting to include young people in the intervention where the parent could have alcohol dependence or not. I'm presuming that you've got a broader definition of problematic alcohol use.
Yeah,
Great.
I mean, this 6-item screener, you don't know if they have what kind of level of problems the parents have.
And did you actually measure consumption, or was it just the audit C?
It was audit C,
Right.
and that's
Okay.
also a screener.
Yeah. So it won't necessarily tell you about levels of consumption. Stephanie, did I see you waving your arm again? No.
You just asked the question I was going to ask. That's fine.
Oh, good. I'm ahead
Yeah,
of you.
about the audit C. Yeah.
Good. Okay. Really interesting, Tobias. Thank you very much. Looks like we've come to the end of our interrogation of you. After that really, really good presentation and very interesting. I think we'll all be looking at your institute's website and afterwards and looking at all the other studies that are ongoing in your institute. Thank you very much indeed. I'll just quickly mention the next webinar, which is going to be on Thursday, the 20th of March, so in 2 months' time. Hopefully see you all there. The webinars are slightly different time. We're doing Seattle, West Coast, USA time. And it will be Dr. Debriella Jacques, who's going to talk to us about maternal alcohol dependence symptoms and maternal insensitivity to children's distress and nuanced pathways and associations underlying early childhood adjustment. That's a mouthful of a title, but you'll get a notice coming out, an Affinet notice via email or whatever, to let you know about that, and you can register for the next one probably fairly soon, I think. So many thanks again to everybody who's turned up today and listened to this, and many thanks especially to Tobias for presenting. Thank you
Thank you
all.
very much for having me.
You're welcome. Thank you. Okay, and we'll see you all in